Hello, and welcome to another educational infographic learning package from Professor Mohammadi's Teaching Archives. Today, we will discuss an important topic in child and adolescent trauma care: how to approach pharmacotherapy for PTSD in adolescents when psychotherapy is unavailable. This infographic presents the case of a 16-year-old girl from Gaza. She witnessed the death of her neighbor during violent protests and has continued to experience significant psychological symptoms for the past 5 months. Her symptoms include hypervigilance, aggressive outbursts, difficulty concentrating, and recurrent flashbacks. Unfortunately, trauma-focused cognitive behavioral therapy, often considered the preferred psychological intervention for PTSD, is not available in her setting. The key clinical question is, what pharmacotherapy approach is most appropriate in this context? The correct answer is fluoxetine for PTSD and comorbid depression with close monitoring. Let us examine why this is the most appropriate option. First, it is important to understand that currently no medication is officially FDA approved specifically for pediatric PTSD. However, selective serotonin reuptake inhibitors, or SSRIs, particularly fluoxetine, are among the most commonly recommended medications when children or adolescents with PTSD also develop associated depression, anxiety, sleep disturbances, irritability, or functional impairment. In this case, the girl has persistent symptoms lasting 5 months, including emotional dysregulation, intrusive symptoms, and impaired concentration. These symptoms significantly affect daily functioning and warrant active intervention when psychotherapy is unavailable. Fluoxetine may help reduce intrusive memories, anxiety, hypervigilance, depressive symptoms, sleep difficulties, and emotional dysregulation. The infographic also highlights several important principles regarding SSRI use in adolescents. Treatment should begin with a low dose and increase gradually. Close monitoring is essential, especially during the first few weeks, because some adolescents may develop increased agitation, behavioral activation, or suicidal thoughts after starting antidepressants. Family education and regular follow-up are therefore critical parts of safe treatment. Now let us discuss why the other options are less appropriate. Option A suggests olanzapine for aggression and mood stabilization. Although antipsychotic medications are sometimes used in severe psychiatric disorders, they are not considered first-line treatment for trauma-related aggression in PTSD. They also carry significant risks, including weight gain, sedation, metabolic syndrome, and long-term adverse effects. Unless there is severe psychosis or another clear psychiatric indication, antipsychotics should generally be avoided as first-line therapy. Option C suggests diazepam as needed for hypervigilance. Benzodiazepines are generally contraindicated in PTSD. They may worsen emotional disinhibition, interfere with trauma processing, increase dependence risk, and have limited evidence for improving core PTSD symptoms. In adolescents, benzodiazepines may also impair cognition and emotional regulation. Option D suggests relying only on prayer and family support. The infographic emphasizes an important cultural principle. Family support, spirituality, and religious coping are extremely valuable protective factors in Gaza and other Arab societies. These resources should absolutely be respected and integrated into care. However, moderate to severe PTSD symptoms that persist for months often require active medical and psychological treatment in addition to family and spiritual support. Support alone may not be sufficient when symptoms significantly impair daily functioning. Another important section of the infographic discusses cultural sensitivity. Children and adolescents exposed to war and conflict may express distress differently depending on cultural background. Effective treatment should combine evidence-based medicine, family involvement, community support, and respect for spiritual beliefs. The infographic also outlines practical clinical steps. These include starting medication slowly, reassessing symptoms after several weeks, educating both patient and caregivers, monitoring safety carefully, and maintaining regular follow-up. The final message of this infographic is extremely important. When psychotherapy is unavailable, compassionate and evidence-based pharmacologic care can still make a meaningful difference. Medication alone is not the entire solution, but when combined with family support, psychoeducation, cultural understanding, and careful monitoring, it may significantly improve functioning and reduce suffering. Early intervention matters. Healing is possible. And even in humanitarian crises, thoughtful trauma-informed care can change lives. Thank you for joining this educational review from Professor Mohammadi's Teaching Archives.